Great, thank you. I want to start by thanking the organizers for this kind invitation to give this presentation. So, we are in Stockholm now, and usually I work down here in Malmö and Lund. So, welcome to Sweden all. So, let's start with a short background. We have the erythrocytes, the red blood cells, and these are packed with hemoglobin, the molecule of interest today. So, the hemoglobin consists of 4 globin chains put together. We have 2 alpha globin chains and 2 beta globin chains. And the alpha globin chains are encoded from 2 genes located on chromosome 16. And we get 2 copies from our mother and 2 from our father, so we have 4 alleles. The beta globin chain are coded from a gene located on chromosome 11. The hemoglobinopathies are often divided into 2 groups. When we have genetic variants that cause a decreased production, we have a thalassemia. And if we have a decreased production in the alpha globin genes, we have alpha thalassemia. And since we have 4 copies, we can have a genetic variant causing the loss of function of 1, 2, 3, or 4 alleles. And here we have a disease that can be very mild or not even detected. And we have all the way to the very serious, lethal alpha thalassemia that needs to be transfused in fetal life if they are to survive. We also have the beta thalassemia when you have genetic variants that causes decreased production of beta globin. The variants, we have a change in the proteins in the amino acid sequence. So we get a change of protein function. And some examples are listed. For the alpha globin variants, we have, for instance, hemoglobin constant strain. And the beta globin variants, we have sickle cell hemoglobin S, sickle cell trait if you're a carrier, and sickle cell disease if you have either homozygous genetic variant or a combination of variant of thalassemia. And hemoglobin C, E, and D are also common hemoglobin variants in the beta globin gene. And many variants are named after the city where they were first described. So we have some variants from Sweden as well, like hemoglobin Stockholm, for instance. So the patients, who do we investigate for these disorders? Well, the anemia, low hemoglobin, is the most common cause to do these investigations. The patients come from all over the world and all different ages. It can also be due to family history, and screening is common in many countries, but unfortunately not in Sweden. We can screen both newborn and in pregnancy. But also other symptoms, because variants is not always an anemia. It can be a high hemoglobin level. It can be decreased oxygen delivery, cyanosis, or increased liver or spleen, or the crisis seen, for instance, in sickle cell disease. So let's go over to the analysis. We have 3 groups of analysis present in our toolbox. We have the routine blood tests, for instance, hemoglobin level and iron profile. Then we have the protein analysis, and we have the genetic analysis. In the routine blood tests, in the routine blood tests, we measure the mean cell hemoglobin level and also the mean corpuscular volume. And as you see in the blood film picture, if you compare it to the first one I showed you, these cells are smaller and they also have a central upclearing, showing that there are reduced hemoglobin content in these red blood cells and also a reduced cell volume. And this is seen in thalassemia, both alpha and beta, but it's not specific. It's also seen in iron deficiency anemia, which is the most common anemia in the world. We have the protein analysis, or the fraction of hemoglobin. That is the second group of analysis that we need to use. The most common methods today are high-pressure liquid chromatography and capillary electrophoresis, but many other methods exist as well. Here we can quantify the level of hemoglobin A2. And if you have an increased level of hemoglobin A2 compared to the blood analysis I previously showed with a lowered MCV and MCH, this is indicative of beta thalassemia trait. As you see, down here, we have a picture from the high-pressure liquid chromatography. Here is the hemoglobin A2 level. This is a picture from the capillary electrophoresis, and this is the corresponding hemoglobin A2 level. So this is a patient without any signs of beta thalassemia, and this is a patient with a beta thalassemia trait with increased hemoglobin A2 level. We also look at this peak, the normal hemoglobin, to see if there is a normal hemoglobin peak present, and if not, it's indicative of a beta thalassemia major. We also see variants, then we get an extra additional peak in the chromatograms. So these are the things we can detect with these methodologies. The genetic analysis. Well, actually, for alpha thalassemias, there are no protein analysis or blood count that is specific enough, so we need to do genetic analysis. Also, if we see a hemoglobin variant and we are not sure of which one it is, we can, of course, verify it with the genetic tests. We can also verify which genetic variant causes the beta thalassemia. And in family investigations, it's of importance to be able to tell which mutations are seen in the family. And also in special cases when we have a difficult hematological picture or combinations of alpha, beta, delta, so on, then it's very useful. And there are more than 1,500 described genetic variants in the hemoglobin database. So the genetic analysis, when it comes to alpha thalassemia, it's more often a deletion that is the cause. And in beta thalassemia, it's more often a small base exchange or a small deletion. And it's actually needed to use different methods to detect large deletions compared to smaller variants. And also a lot of methods exist that are designed to detect a certain variant or a certain deletion. So if you use that kind of methods, you will not detect other deletions or mutations than they're actually designed for. And then there are some methods that detect both deletions and variants, but just the ones that they are designed to. And there are broader methods like Sanger sequencing, where you can sequence the whole gene, and MLPA, where you can detect deletions. And that does not have to be specified prior to the analysis. And also we have a new technique that has been in use many years, next generation sequencing, that is also upcoming in this part. So you need to have a clinical question as always, and you need to know who is the patient. And then in these disorders, you need to combine the routine blood test, the protein analysis, and sometimes the genetic analysis. And keep in mind that you might need different methods to detect genetic variants. So, some references, and thank you for your attention.